Okay, so dystonia management and practical solutions. So we have Dr. Nivedita Thakur here with us. She's the associate professor in the development of pediatrics at McGovern Medical School at UT Health and formerly at CHOP. So she specializes in pediatric movement disorders and neurodegenerative diseases, and actually sees some of our family members here. So Nivedita, if you want to come up. Thank you.
Perfect. Okay, thank you. So thank you for having me here come to speak today about dystonia management and NBIA disorders. I really hope that we can have a little bit of a conversation, so I want to try to wrap up my talk and then hopefully get questions and try to see if we can have some further conversation, because I know many of the families with their loved ones have encountered dystonia, and I think have some important pearls that they can share with everybody. So what I want to first talk about is tone, muscle tone, and kind of define that, because this is something that we'll encounter when we're seeing patients, and when you're seeing loved ones. What you do notice with muscle tone is that there may be differences. So what is muscle tone? It's the tension in the relaxed muscle or the resistance to passive stretch. We know that muscle tone involves connections between your brain, spinal cord, and muscle spindles. There's a complex network that's involved in us having our muscle tone. So when we think about tone problems, there are three important aspects that can be brought up by physicians caring for patients with NBIA disorders. And so I thought, though we're going to be focusing on dystonia, there may be other terminology that gets used, and I think it's important to know what are the similarities and differences between it. So dystonia is this involuntary, it can be sustained or intermittent muscle contraction. It fluctuates, which makes it particularly hard. And you would often notice that there's abnormal muscle posture as a result of that. It's velocity independent, which is important because when we're thinking about spasticity, which some patients can have spasticity and dystonia, there's a difference there, and we'll talk a little bit about it. It does fluctuate, which means that it can be tricky. You can be in one instance where the muscles seem really relaxed, and then other times someone can be as stiff as a board and you can't really do anything, which is really hard. What we know about dystonia is that it does improve with sleep, which is a little bit different than spasticity. And dystonia is definitely impacted by certain positions that we're in, our emotional state, if we're in pain or stress. And so it's important to know that those are also playing a role in whether we're seeing the dystonia being present, or it may not be present at times. And typically when patients do have dystonia, they can have normal reflexes, which as a physician, when we're assessing patients, that's something that we're looking at when we're doing the neurological exam. But what's interesting is that sometimes it can be accompanied by underlying hypotonia or low tone. And I think that's important. That's a terminology that you may hear where the muscle tone just feels a little bit looser than you would expect. But then that looseness, for example, if the dystonia kicks in, gets really tight. So dystonia is different than spasticity, and this is where a lot of physicians actually don't get it correct, and they will use these words interchangeably, but it is really two different entities. So spasticity is that hyperactive stretch reflex. So often, when you're moving the extremity, you feel this resistance to passive stretch. And sometimes there's words like a spastic catch that the doctor may say, or you may feel as well, that as you're moving the muscle, you're feeling this catch. And it is dependent on velocity, which is different than dystonia. And what we do know that's important is spasticity doesn't fluctuate like dystonia. So that's an important pearl to know between the difference when you're thinking about spasticity and dystonia. And it's usually the same in the sleep-wake state. And with spasticity, we can often see hyperreflexes, which means that when the doctor is checking and doing a neurological exam, they'll notice that the reflexes are really brisk. Sometimes they'll kick their leg out really quickly when they're assessing those reflexes. Or you may sometimes notice clonus, which is the shaking when they're doing the neurological exam. And then lastly, I wanted to talk about rigidity, really in terms of Parkinsonism. But rigidity isn't necessarily something that you may notice in the beginning, but could be a feature that you notice later on in the progression in the NBIA disorders. And so like dystonia, it is velocity independent. When you're feeling patients and as trying to kind of assess whether there's rigidity, what you feel is that there's this constant elevated tone through that passive range of motion, and it feels like it's cogwheeling. It's when you feel it, you sort of know it, that this feels different than spasticity and dystonia. And so that's a hallmark, that cogwheeling that you can feel. We know that it can improve with sleep, and it's often seen in Parkinson's disease, but for a lot of our patients that have Parkinsonism, you may see it there, and it may be associated with tremor as well. So I just wanted to take a little bit of time to talk about these things because these are words that may be used, and I think for families it's important to understand that these are different. And so, some things from a treatment standpoint can overlap, but then in other instances there are different treatments. So let's talk a little further about dystonia. We talked a lot about what happens to the muscles, that there is this contraction that's happening between muscles that really should be working in synchrony. So certain muscles need to relax while other muscles are tightening in order for us to move our body. But what happens in dystonia is that those muscles are tightening at the same time. And so often you'll have these abnormal muscle movements. Sometimes it's focal, meaning it's in certain areas of the body. So a great example of that is torticollis. So in torticollis, you just have this involuntary contraction of muscle that tends to make you move your neck in a particular direction. And so, often patients will favor keeping their neck in one position. And that's the dystonia that you're noticing in the neck. Other times it can be things like eyelid spasms where you can have this involuntary eye closing or excessive blinking. We know that dystonia can impact, can be focal, but then impact, your whole body where you're seeing it in multiple different areas of the body. And then another area where dystonia can really play a role is with speech. And often what you'll see is dysarthria or trouble speaking, along with dysphagia, where you have trouble swallowing. And really the issue is that those muscles are not coordinating the way they need to in order for us to do the motion to, for example, chew our food and then be able to swallow it. And probably the most kind of severe or really stressful time with dystonia is often when you've got a dystonic storm or a dystonic crisis. And it's really hard because with loved ones, what you end up seeing is that the dystonia is so severe that you're obviously able to see that in their body, but you're also seeing changes in their heart rate. They become tachycardic. They can have a fever. You see changes in their respiration. Their blood pressure can go up, and there's autonomic instability. And that's a lot of times instances where families need to take their loved ones to the hospital to get assessed if it's the first storm, or come up with a plan of what medications do we use if this were to happen, and could we manage some of this at home if possible. So, talking a little bit about what happens in a dystonia and why it occurs, we know that dystonia is a circuit disorder, which means there's dysfunction within the complex network of the brain regions and pathways involved in motor control. The dystonia network involves the cortex, the basal ganglia, the thalamus, and the cerebellum. So that's a lot of different parts of the brain that are part of this circuit. And any dysfunction in any of these areas can lead to dystonia. And so that's an important thing that we want to think about, that it's not necessarily always one spot in the brain, but there's multiple areas, part of the circuit, that can be abnormal, that can lead to dysfunction. So I want to talk a little bit about neurotransmitters because I think it helps us better understand why certain medications are used. We know that dystonia involves alterations in several neurotransmitters in the brain. So GABA, acetylcholine, dopamine, glutamate play really important roles. Other neurotransmitters like serotonin and noradrenaline may also contribute to the pathophysiology, especially the non-motor symptoms. So, I just wanted to highlight a few of these. Again, neurotransmitter GABA is one that you may hear a lot about. The GABA neurons really help calm our nervous system down. And so you'll see that several of the medications that are used as options really try to use that GABA system to calm our nervous system down. The cholinergic and then the dopaminergic are the other ones that play a role. And so what I'll do is just kind of shift gears, and hopefully you guys can see this, but this is a list of many different medications that can be used for dystonia. I think what's frustrating for a lot of families is many of these meds are used for dystonia. There's not a lot of new medications out there, but for most patients, there's a combination that people start off with one medication and then we try to figure out what's the best combination that's helpful for patients. We know that these medications for dystonia target neurotransmitter imbalances in the brain. So for example, Artane or trihexyphenidyl is used at, targets the acetylcholine and blocks acetylcholine, which we know is important in muscle activation. That's one that a lot of our patients are on. Another example is baclofen. Baclofen targets the GABA receptor. It's actually a GABA B receptor where it helps, again, to calm that nervous system down. Clonazepam is another example, along with diazepam and Ativan. The benzos can be used to help, and some of this can give you relief right away, and then others are a little bit more long-acting. The dopaminergic are interesting, like there's Sinemet and then tetrabenazine. So they work, carbidopa levodopa actually gives you dopamine versus tetrabenazine, which actually inhibits the amount of dopamine that you get. You do want to be careful using these medications. These aren't ones that are necessarily the go-to in the NBIA disorders. But for example, Sinemet may be potentially an option to consider, especially if you're having a lot of the Parkinsonism symptoms, for example, and you need a little bit more dopamine. The other medicines that I think are important that you may encounter are gabapentin and clonidine. These aren't necessarily ones that you may think of, but they have been shown to help in terms of calming the nervous system down. And so these are some great options that can be considered. Again, a lot of these medications, because they're calming the nervous system down, one of the biggest side effects is sedation. And so you're really trying to balance the benefit from these medicines with potentially side effects. Tizanidine and dantrolene are other ones that can be used. These are kind of more of a muscle relaxant. And then I think Botox I have there, this is one that I think for a lot of families can be helpful, especially if there's focal dystonia that is really problematic. Using Botox can really be helpful in getting that relief. So that's an important consideration as well. So, when we're thinking a little bit, like I said, I've kind of gone over these slides, so I'm just going to kind of go through these. But like I said, there's not one medication that's helpful for every patient. I think it's trying to find the best medication with the minimum amount of side effects. And then oftentimes as the dystonia is getting worse, trying to find a combination that works really well. And one of the other things that, I will say is that Some medicines, we know that kids can tolerate much higher doses than adults, and we know that our, that some patients that do have NBIA disorders, they are at much higher doses of medicines than even a lot of pediatric neurologists would be comfortable. And they're like, oh my gosh, this is so much medicine. But we just know that if you go up on the medicine slowly and you're monitoring for side effects, that a lot of times they do tolerate much higher doses. Now, that being said, it's always really important when you do have medicines and you are talking with your doctor to have that conversation of, are these medicines helping? Do we need to consider coming off of any medicines because it may not be helping at this point or potentially having side effects? So having constant conversations, I say every 6 to 12 months, talking to your physician about whether this combination you're on is the right combination is really important. And I think that that's something that families do a great job of asking, because often I've seen patients come in and they're just one medicine added after another, and then you're just on so many meds and you don't know whether that medicine that was started 2 years ago is still helpful or not. So I just wanted to, talk a little bit about what happens when dystonia increases and you're potentially in a crisis. And I think this was a great consensus article on PCAN where they kind of went through, well, we need to look and see what may be going on. And so there is some importance in trying to figure out what may be triggers. We know that dystonia definitely has more triggers in terms of, could this be constipation? Is there an infection going on? Is there potentially some sort of fracture or some sort of injury that's happened that we need to identify? So trying to identify triggers is really important in dystonia. And then obviously, sometimes it's really important to try to see if medicines need to be escalated, but then also, you need to do it in the acute setting, but you may not necessarily need to be on it long term. Sometimes the dystonia is so severe that you do end up needing to be sedated and need medications to help let the body and muscles rest and relax. But then, like I said, this is kind of the more extreme circumstance where you're typically hospitalized and being monitored very closely. So I want to highlight a little bit of some surgical options for tone management. The reason I bring up a few of these other ones, which may not necessarily be pertinent to dystonia, is because I think our families need to know about what options there are and what may not be good options and what are options that may be important to consider. So probably the two big things that we consider as surgical options is intrathecal baclofen and deep brain stimulation. But the reason I have these other two up, selective dorsal rhizotomy and neurectomy, is that often when people are talking about tone, they may suggest this, but it may not necessarily be the best option for dystonia. So I want my families to be aware of this. Selective dorsal rhizotomy is actually a procedure where you cut dorsal rootlets in the spinal cord, so in the back at the bottom. There are dorsal, and those are your sensory fibers. Those are the rootlets that help us sense what we're feeling. And this procedure, done in the right patient for spasticity, can be helpful, even for palliative reasons. But what we've learned is that if you have significant dystonia, this type of surgical procedure actually is not helpful. And so you want to be careful if someone is suggesting that. And then neurectomy is the other one. They're using that a lot in the upper extremity, so they'll identify certain nerves that may be problematic from a spasticity standpoint and do a procedure similar to a dorsal rhizotomy, but it's just an individual nerve that they end up cutting, and that can lead to decreased spasticity. Again, not very helpful for dystonia. So the two that I want to focus on is intrathecal baclofen pump and deep brain stimulation. So because a lot of our patients are on oral baclofen, often what you end up seeing is that they're on higher doses and we're not seeing much benefit. And so often what we end up doing is doing what's called an intrathecal baclofen pump trial, where you have a lumbar puncture and they actually give you the baclofen and you see whether they're responding to that. And what we see is that, because systemically, when you take oral baclofen, it gets absorbed more systemically, so not much makes it into the central nervous system. And so that's why you can never really be on the doses you need to be in order for it to be effective for our nerves and muscles. And so a pump is a way that we can deliver the medication directly into the nervous system. Now, some of the challenges with a pump is that it is a device, right? There's benefits to it that you can deliver the medication directly where you need to, but the disadvantage is that because it is a machine, it can malfunction. And so you really want to make sure that you have access to a place where you have good follow-up. There is medication that is in this pump, and so that has to be refilled. So you need to make sure and be able to get that done. Depending on how high your dose is, kind of determines how often you need to get that pump refilled. So there's a big commitment to follow-up and close monitoring, both by the family but also by the physicians. And so it's a serious consideration, but it's one that you want to think about as a potential option, especially if you're thinking that the baclofen is being helpful, but you just can't get to doses that you really need to be. And then DBS is a way that you can try to target some of the dystonia, because we know that a lot of what's going on is happening in those different areas of the brain. And so with DBS, you put a small electrode and it delivers electrical impulses to a focal region of the brain. And in this case, it's an area of the basal ganglia called the GPI, the globus pallidus interna. And we know that the impulses that are being sent disrupt the abnormal signals that are going on in the brain that's leading to the dystonia. And so if we disrupt that bad signal, what ends up happening is patients have relief in some of the dystonia. I think some of what needs to be done a little bit better is, when should a DBS be put in? And what we're also realizing, especially when we have conditions where it is progressive, is, are we putting in a DBS too late when things have really progressed to the point where putting that DBS really doesn't make a difference for that patient? So should we be doing it potentially earlier? And there's some data to suggest that maybe that's something that needs to be thought about and talked with families, and discussed whether that would be something worth considering a little bit sooner in the clinical course. And then I think, the important thing with DBS is that, because you're dealing with a condition that is progressing, you may see benefit for a period of time, but it may not be sustainable. So I think having realistic expectations. I think the technology is definitely getting better with DBS. I think it is being able to be put into kids in ways that we weren't able to before, because again, this was designed for adults with Parkinson's disease. And so having these things being put into a child, you really needed to make sure that that was feasible for little ones. So, I think we're getting more information that's going to help us better understand who the right patient is to put the DBS in, and hopefully what's the best time period to do that. So I want to shift gears now and talk a little bit about practical solutions, the non-pharmacological management of dystonia, which I think is very important. I work with Sarah, who is a physical therapist at UT Houston, and I think she's taught me a lot from a therapy perspective on what you can do to really help in managing dystonia without adding on another pill. So if we can we just shift the presentation to that video now, please? Thank you.
therapeutic interventions that support movement, tone management, and functional independence in individuals with NBIA disorders. My disclosures are that video consent has been obtained from patients and families for those videos that are used within these next few slides. So these are some general considerations when we are looking at therapeutic strategies for individuals with NBIA disorders. First of all, starting out with just a good assessment. The difficulty in providing strategies for individuals that have changing needs over time is really to take a step back sometimes and think about where we are now. Reassessing strength, reassessing any musculoskeletal changes, making sure that we are supporting any type of musculoskeletal alignments, preserving that alignment, and making sure that we're providing that good musculoskeletal foundation for movement, assessing tone pattern, assessing any changes to tone that have happened in the recent past. Sensory processing of the individual. So this is an area that I talk about in some depth in other discussions and other presentations, but an area that I think we're exploring and learning more about. We know that individuals with NBIA disorders do have visual, perceptual difficulties. There is some evidence that we're also finding some proprioceptive deficits, possibly auditory, possibly vestibular. These are all areas of sensory processing, not only how they function independently, but also how they function together to optimize movement. So it's an area that should be looked at. Talk to the experts who are usually your occupational or physical therapists to really get in there and discover if these are areas that might be affecting function. Also an area is pain that should be evaluated. I think this is an area that really needs to be assessed accurately to determine what the cause of any discomfort. I think that we sometimes, especially for individuals who are nonverbal, we make assumptions and don't always really get at the root of what might be going on. So being able to really assess the discomfort, is it positioning? Is it the dystonia? Is the equipment too small that you're positioning an individual in? Those are all things to really consider. And then as well as functional skills. We need to ensure that any adaptive equipment needs are met to maintain mobility, to maintain function, and also to support caregiving. And I'll give some examples. Ensure that appropriate ADL needs are met. That's activities of daily living, and that can include activities of daily living. It includes brushing your hair, getting dressed, brushing your teeth, those things that you need to get ready on a daily basis. And making sure that there are some adaptive hygiene tools that may be helpful to have the individual participate in their ADLs, feeding utensils, leveling spoons, adaptive knives, other types of utensils to ensure that we're optimizing function. Ensuring appropriate communication needs are met to preserve engagement and connection. An area that is vital in ensuring that the individual feels connected to their environment, to their family, to their community. As we talked about, pain relief activities or modalities that can include wheelchair positioning, bed positioning, manual traction, mobilization. I'm very often will show families how to just manually traction joints and mobilize whether it be the neck or the trunk or the limbs. That can be very nice to be able to provide some relaxation and pain management. Massage is also a great way to a great strategy for pain relief. And then that each exercise program, each therapeutic intervention really needs to be individualized. Includes any types of strengthening activities, range of motion activities, passive or active, tone regulation activities, which we'll go into in a minute, and functional skills as appropriate. So just reviewing equipment briefly. Those orthotics, splints, any types of devices for the trunk support can really help to preserve musculoskeletal alignment. It's much easier to preserve musculoskeletal alignment than interventions that you would need to change that in the future. So what am I talking about? I'm talking about pronation of the ankles. I'm talking about tight heel cords, tight hamstrings, talking about hips that rotate, talking about scoliosis. Those types of things that if we really assess and we look at on an ongoing basis, we can provide some pieces of equipment, strategies to be able to preserve that alignment. Wheelchair and adaptive seating. We have this young girl here who has her manual wheelchair that has the adaptations that are necessary for alignment. We use standers, gait trainers, walkers, overhead lift systems, which I think are a very important item to look at for families. I think that sometimes we look at lift systems when we really, really need them. And that's difficult. It's difficult. It takes time to get them, assess for them, and request them. And it's much easier to have that in place. So I hear from a lot of families that, well, we're doing fine, they're light enough, we can lift them, and which is great and true in a majority of the situations. But it's really nice when you have that back injury or we're getting up there in age and the lifting, it just gets away from you, and the lifting just seems to be getting harder and harder. And having that lift system in place ahead of time is the ideal situation. Adaptive beds, I'm a huge proponent of ones that have elevate the head, elevate the legs, and provide some positioning for the individual for comfort. Sleep is so important for function and for health. So being able to have adaptations within the bed so that so that everybody in the household can get sleep. As we discussed in the slide before, any kinds of activity of daily living items, those can be back sponges, those can be reachers, those can be, again, utensils for feeding, built-up grips to make holding a toothbrush easier. And then augmentative communication, which is really, again, that piece of keeping the individual connected. So this is, just wanted to play this quick video of this young girl. Who is using her augmentative communication system.
She said, when's your birthday?
When's mine? April 3rd.
Oh, coming up! Happy birthday!
So she's in the middle of her visit with her doctor, and she's able to engage, she's able to ask the doctor questions, she's able to feel like she's a part, and not that people are talking about her or around her, but that she's engaged in the conversation and is asking the questions that she wants to ask.
I think we may have to, just forward it. Yeah.
So these are just some examples of some of the orthotic and support items that I talked about. This first one is in AFO. So it's an ankle foot orthotic. There are many, many different designs and should be taken individually according to what your physical therapist recommends, your orthotist recommends, your doctor recommends. The middle item is a compression garment, and this one in particular is called a SPIO. I find that compression garments are particularly helpful, not only for alignment of the trunk, improving core strength, but also for that proprioceptive input, and also for calming. So when we're working with someone who has dystonia, this type of garment can be very helpful for calming and for providing that compression support for an individual with dystonia. The items, item to the right of the screen and on the bottom are different types of hand splints to maintain an open hand. That's not only for hand function. A lot of times these splints are meant for sleeping and just to maintain the range of motion within the hand. But also it's really important for hygiene, to be able to get into the hand if we are experiencing some strong dystonia that leads to fisting. It's very important that we be able to get into that hand. So splints can be very helpful with that. And then the bottom is an example of a Bennex splint. And I use this type of splint sometimes for access to augmentative communication devices. It provides the pointer so that the individual can use or isolate that one digit to be able to make accessing the device manually a little bit easier. These are a few more items that I talked about in the slide before. This first one is a stander. And again, there are many, many types. These are just some examples. This one in particular goes from sit to stand. So you place the individual in the sitting position, and then the stander goes to a standing position. Huge advocate of standing for tone management. Weight bearing is a strategy to be able to decrease tone along with a good positioning. It also can assist with bone integrity. The gravity can help with gastrointestinal. Being upright can help with respiration, and also just being in a standing position, facilitating your cognitive development and your engagement with your community, your family. The one up to the top is an example of an adaptive bed. This happens to be a Sondercare bed. Again, there are all different types of items that you can get, but this is an example of a bed that you can raise the head and the feet. That is not as hospital-like as some of the beds that are out there. This item to the top right is a shower chair. It's a roll-in shower chair that you can position the individual in. It tilts back. You can use a hand wand for being able to wash their hair. I like the tilt feature on that. It can be invaluable. To the bottom right is an adaptive wheelchair, similar to the one the young girl was sitting in, and this is, again, happens to be a Quickie Iris, but there are all different types of adaptive chairs that you can be evaluated for by your physical therapist, occupational therapist, and durable medical provider. And then this last picture is a Sure Hands lift. This is a barrier-free lift. One of the complaints that I hear from a lot of families for lift systems is that they are big and bulky, and I just can't move them around my house. Many reimbursement funding organizations, insurances, Medicaid are paying for these barrier-free lifts, and it's a track system that can be installed in the house, and it's a great way to be able to move the individual from bed to chair, bathroom, depending on where you put the track systems. Okay, so now we're going to dystonia management. So there are many techniques for dystonia management that are non-pharmacological. I use techniques such as weight bearing through the upper and lower extremities. You can do this in sitting and standing and quadruped. I use rhythmic weight shifting in both sitting and standing, rotation of the spine and the extremities to break up that posturing. So some sensory considerations, there's a real connection between dystonia and the way that our bodies process sensation. So having that real firm hand hold on the individual, light touch can actually lead to more facilitation of tone. And so really approaching it from a little bit of a heavier hand, not too much squeezing, but a little bit of a heavier hand to be able to provide some calming. Providing proprioceptive input through weight bearing, overpressure through joints of the extremities and spine. And I have a couple of videos that I can use for examples of this. Consider any visual deficits and try to incorporate the vision as able. If you are feeling like you really don't know where your body is in space, some of the dystonic posturing can come from that feeling of stabilization. So using vision to give a target and asking the individual to really focus on their visual skills can help for them to feel a little bit more coordinated in their body where they are in space and can help to decrease that posturing. I use a lot of co-regulation through my own rhythmic breathing. When I'm working with someone that has dystonia, I try very much to slow down my own breathing and ask them to, just breathe along with me. I take deep breaths so I can show them just in and out, trying to get their breath to be more calm, more rhythmic. I give slow, regulated verbal instructions for movement. We're going to move this way, and then we're going to go in the other direction.
We can pause the video. I think we're out of time.
Here.
Sarah actually ends up showing 2 videos where she's kind of demonstrating this, which I think can be really helpful. I think for a lot of families, being able to come up with things you can do at that time when the dystonia is kicking in, where it trying some of these strategies, I think have been helpful. So I just wanted to stop because I know I ran out of time and I'm so sorry about that. But do you guys have any questions or anything that I can try to answer? You want to see the video? I have the video. If anybody's interested in seeing the videos, I'll have my laptop over here and I will play it for you guys. Yeah. Yes. Yeah, I do think that either one can be effective, so I think it's worth trying it. I have had some patients that are on Botox that get switched, and vice versa. So I think it's worth trying to see if there is any differences in terms of benefit that you're seeing, even if, try it. I don't think that there's necessarily one that absolutely works well. If there is one that's working well for your loved one and you don't want to switch, I think obviously try to advocate and see if the insurance will. Sometimes they're really tough about it and they won't. Give the other one a try. It's worth trying and seeing. At least that way, if you do feel it's not, then they can use that when they talk to the insurance the next time and say, yes, we've tried it. It doesn't work. We need to be on the Botox. Get used to it. Yeah. So I think there is some of this in terms of could there be like a phenomenon where you're getting used to it? I will tell you the PM&R and other experts, you know, you use what you need to, but I have seen in some cases where you have been on one for a long time and switching over does prove to be helpful. So there is something to be said. I think it's hard when things are working well that you don't necessarily want to change, but I think it's worth looking into. Yeah. Anybody else?
Hi, my question is about the DBS.
Yes.
My Kobe got his first DBS, and they programmed it, and he was able to open his hands and grasp and start using it again, but it got infected.
Okay.
And during taking out of the first one, there were some complications, and because of some decisions that was made, he went into a real bad state where he had severe pain and everything. So when he was able to get it again, months later, it was decided to manage his pain. And that's what we've been doing for the last couple of years. So from that, would it ever be able to, with your knowledge or your understanding, to go back and maybe work on certain areas to try to give him use of his extremities again and stuff, or do you think we're past that point? And I know you don't know him individually and stuff, but because we're managing pain right now, but he performed so well on that first programming, you know, we wonder if he'll ever be able to get some abilities back.
So has he gotten a DBS again? He does
Yes,
have a
he
DBS
got
now?
the second one in now, and
Okay.
We're just managing pain so far.
So they haven't turned the DBS on?
Yes, it is.
It is.
And he's just, they're not like working on trying to, and he maintained that first programming where he was able to open his
Yeah.
hands and grasp his toys. He's maintained that even after it was
Good.
taken out.
Okay,
So that
great.
made him a good candidate to have it again,
Sure.
the neurosurgeon said, and he got it. But there were some decisions made while he was recovering that had some bad things happen. And so he was just in severe pain, so they just saying they was trying to control his pain and get him comfortable again.
Sure.
And no one has, in my team right now, knows if they'll be able to go back. So I was just like wondering with y'all experience and everything, would it ever be able to, you know, be used to just help him with his arms or legs or something like that again?
Yeah, I think one of the things it's worth talking to the doctor about is if they would consider looking at some different settings for him to see if it can help with function. I think one of the things the reason they're focusing on the pain is because they feel like maybe that's a big driver for the dystonia. And if they can get that under control, then that would maybe help to kind of figure out what is his baseline dystonia without that pain in place. And then, you know, I think the tricky thing with DBS is that, you know, you're working against some progression. And the question is that with that progression, are you going to be able to get back some of that function that you're hoping for? And that can be tricky. But I think talking to your doctor and kind of figuring out where he is and whether that would be, I mean, I think it's worth trying and seeing if different settings can be helpful. There's times that they can program it so that you have different settings that you can use and try. So you always have the one that's your home base, the one that's been working, but the other ones that you could see whether there's some benefit there. Yeah.
Question?
Yeah.
Earlier in your slides, you used a term that I'm not familiar with. You used the term velocity dependent. Can you explain velocity dependent and velocity independent, please?
Yeah, that's okay. So when you see physicians, and even, you know, if you're trying to examine, you'll often notice when you're testing for spasticity and tone issues, the muscles have to be relaxed, which can be tricky because sometimes you've got someone who's not necessarily wanting to be relaxed. But to do a true test to see, your muscles have to be relaxed, and when your muscles are relaxed, you're quickly moving this joint. So it's velocity dependent. The quickness as you're moving it, you'll notice with spasticity that you feel that tightness coming. So it's dependent on how quickly you're moving that joint. So it's a little bit of technical terminology, but the reason I bring it up is because it helps physicians differentiate between spasticity and dystonia, which often gets confused.
Sure. Okay,
No.
thank you.
All right, thank you, Dr. Tucker.
Thank you.